Moving on to the intervertebral disc and the motion segment. The motion segment is defined as any two vertebrae with any intervening structure, so two vertebrae and the disc essentially. The physiological movements that are possible between any two vertebrae are the movements of flexion and extension, lateral or side flexion, and rotation. The amount of movement depends very much on whereabouts in the spine we are. So the cervical spine allows a large degree of rotation, the thoracic spine allows a large degree of rotation, but because of the orientation of the facet joints, the lumbar spine allows very little rotation. So there are primary structures that determine the amount of movement that we have at the spine. Between any two typical vertebrae, there are three joints to consider. So between the bodies of C2 all the way down to S1, there is a symphysis joint, a cartilaginous symphysis joint. This is the intervertebral disc lying in between the two vertebral bodies themselves. There is a thin layer of hyaline cartilage on the surfaces of the vertebral bodies themselves, and there is an intervertebral disc intervening the two vertebral bodies. The fibrocartilaginous discs make up approximately a quarter of the total height of the spine, and the height of each individual disc varies depending on whereabouts in the spine we are. So down in the lumbar spine, they are significantly thicker than they are in the cervical spine. This reflects its weight-bearing role. The disc itself is made up of a central fluid region. So this is the central section here. This is known as the nucleus pulposus. Outside of the nucleus pulposus, there are a series of concentric layers of fibrocartilage, which are known as the annulus fibrosus. There are regional variations in the thickness and in the shape of the intervertebral disc to reflect its function. Within each intervertebral disc, there are four identifiable zones. There is the nucleus proper, the nucleus pulposus. There is a transitional zone in which it's a very jelly-like substance where the nucleus is a bit firmer. Then there is the inner annulus and then the outer annulus fibrosus. The outer annulus fibrosus is the only section of the intervertebral disc that is actually innervated. So this is the only section that will actually give us any pain of any sort. The annulus fibrosus itself is made up of anywhere between 10 and 20 layers of concentric lamellae of type 1 and type 2 collagen. The greatest concentration of type 1 is peripherally, so it's much more ligamentous peripherally, and it's much more cartilaginous centrally. The collagen fibers are arranged in parallel bundles or in parallel layers, but each adjacent layer, the fibers are angled in alternating direction, and this is to allow resistance into rotational or torsional forces. The nucleus, on the other hand, has a very high concentration of proteoglycans and type 2 collagen. It's extremely hydrophilic, so the majority of the nucleus itself is water. At the end of each vertebral body, there is something known as the vertebral end plate. This is a thickening in the cortical bone, and there is a thin layer of hyaline cartilage covering this region. The function of the vertebral end plate is to prevent herniation of the nucleus into the vertebral body itself. Occasionally, the vertebral end plate may be thinner, or it may rupture. This leads to small cystic type herniations known as Schmall's nodes, and we can see Schmall's nodes here on these X-rays. These are fairly common in young males who do high load flexion activities, so things like sports such as rowing, for example. There is a close relationship between the disc itself and the spinal cord. There is the nucleus pulposus, there is the vertebral canal. If the disc herniates straight back, it can create pressure on the spinal cord, as we can see here. Here is a central disc bulge, this red structure herniating, and you can see it's clearly impinging on this green structure, which is representative of the spinal cord. Posterior herniation is unusual because of the presence of a very strong ligament behind here, known as the posterior longitudinal ligament. Posterolateral herniation is more common, and a posterolateral herniation may lead to pressure on a nerve root. The disc is prone to injury and disease. There are different types of problems that we can get with the or different types of injuries we can see within the disc. We can see a small disc bulge or a small disc protrusion, as we see here. We can see a prolapse where the nucleus is actually split through the annulus, or it's got as far as the outer annulus, and that's causing a significant disc bulge. This in turn can lead to pressure on a nerve root. We can see an extrusion, and this is where the disc itself, the nucleus pulposus, has actually split completely through the annulus and is now bulging outwards. And then finally we can see what's called a sequestration, and here we can see portions of the nucleus pulposus that have broken away. Discs may also be prone to degeneration and dehydration, and this in turn has the effect of reducing disc height, which in turn leads to increased pressure on the synovial joints of the vertebral column. Posture has a significant impact on intradiscal pressure. If this is our man standing with 100% pressure on the disc, if we go into a recumbent position or lying down with our legs bent up, it significantly reduces intradiscal pressure. But if we stand in a flex position or stoop forward with a small weight in our hand, we can end up with significant increases in intradiscal pressure, at least double. Sitting and sitting stoop forward also has a significant effect on increasing intradiscal pressure. This in turn will have a tendency to cause a posterior disc movement or a posterior disc bulge. The outer disc is innervated, but it's innervated via a small branch of the nerve known as the sinuvertebral nerve. Here we can see the sinuvertebral nerve quite clearly coming in and innervating the posterior and posterolateral disc. It's only the periphery of the disc that is innervated, and it's innervated with nociceptors, so it can detect pain, and more importantly with proprioceptors and autonomic nerves themselves. Nutrition of the disc is also very poor, so injury to the disc often leads to a very poor result in terms of repair. It gets most of its nutrition via diffusion through the vertebral end plate itself, so we can see here diffusion occurring here through the vertebral end plate. The periphery of the disc has a small nerve supply, a small capillary supply, which can lead to abundant nutrition or adequate nutrition of the annulus, but it's not a good it isn't a good blood flow at all. Posture can have significant impacts on fluid movement, and in particular flexion extension, side flexion is very good at improving nutrition to the disc, as this creates like a pumping effect to the blood vessels themselves. Posteriorly, between the articular processes between adjacent vertebrae, we have a series of synovial plane joints. These are the synovial plane joints here, and they are typical synovial plane joints. The articular surfaces are covered in hyaline cartilage. They're surrounded by a capsule, which in turn is lined with synovial membrane. As mentioned earlier, there are regional variations in the synovial plane joints, not only in terms of size, but also, and most importantly, in terms of orientation. Movements during flexion extension leads to separation and compression of the facet joints, and movements of side flexion and rotation can lead to compression of one facet joint, distraction of the other facet joint. The movements of side flexion and rotation are often called coupled joints, because the orientation of the facet joints themselves often leads to these two movements occurring together. There's a number of ligaments that help stabilize the vertebral column. There are two long ligaments here that run down the anterior surfaces of the vertebral bodies and intervening discs. This is the anterior longitudinal ligament, and over here we've got the posterior longitudinal ligament running down behind the vertebral bodies and intervening discs. These are very strong structures that provide a significant amount of integrity or stability to the anterior and posterior parts of the vertebral bodies. In between the vertebral arches, we have a series of ligaments. We have the intertransverse ligaments that sit in between adjacent transverse processes. We have the interspinous ligament, which are these flat lamina that sit between adjacent spinous processes. We then have the supraspinous ligament that runs all the way down here, attaching to the tip of each spinous process. And in the cervical spine, we have a structure, a large ligament known as ligamentum nuchae. In addition to that, between adjacent lamina, we have this yellow ligament, which is known as ligamentum flavum. And the ligamentum flavum is quite an elastic structure. It's quite a rubberized structure that has a role in behaving like a dynamic ligament. It assists with movements from returning back up from flexion, but it also has a role in preventing excessive inward folding of the ligaments during extension movements. So it has a protective role on the spinal cord and spinal canal itself.